Glad you stuck around for a second half hour. We have the phones open all hour long. If you are a healthcare worker and want to share with us some of what you're going through here with the COVID-19 pandemic, love to hear from you. 800-333-1190 is the number to call. Right now, we're going to jump on the expert line and head out to the Los Angeles area where we're going to connect with Dr. Jamie Rutland, a triple board certified intensivist and pulmonologist, just coming off his shift in the ICU at a hospital there. Jamie, good morning to you.
Hey, good morning, everybody. Thanks for having me again.
How many COVID patients in your care overnight?
So we got one in the ICU right now.
And has that been normal? Have you been flooded? Or are you under control?
I hesitate to use the word quiet, but we were flooded earlier, and now it has calmed a little bit, and the question is whether or not this is the calm before the storm, or if California really did a fantastic job of social distancing and perhaps we already peaked. I don't know. I can't tell you.
Yeah, you guys were way early on locking things down, so maybe you got ahead of the curve. You've had quite a few patients over the past couple of weeks we've talked to you. Tell me what's going to carry forward for you. What's going to stick in your mind? What's the overriding memory you're going to take forward out of this?
The overriding memory, and again, I still believe that this is going to change medicine forever, so to speak. You just, as a physician, as a pulmonary and critical care physician, I lost a little bit of freedom, okay? And what I mean by that is we would float from room to room, and if something exciting or something life-changing was happening, you would just waltz in that room, you would do what you needed to do with your hands or with your brain, and then you would walk out. Now, all of a sudden, every time you get that phone call to go in a room, you have to be worried. You lost that freedom. You don't have that... You're not invincible because a person can seriously have SARS-CoV-2. So that's something that I'm going to take very seriously moving forward, and something that's changed forever. The other thing that I think has changed is, through social media and really through the media as well, I've developed a kinship, a friendship with physicians internationally. And we have all collaborated and put our thoughts together about what we think is happening, why we think it's happening, and it's allowed us to create a conversation that I think needed to be had. And it's just allowed us to come together really as one world, as opposed to just one nation. And I think that I have found that extremely positive. And I look forward to that daily. I mean, I just got a message a few minutes ago from, a surgeon in the United Kingdom in our big healthcare group on our Instagram chat. And so anyway, it's just something that I've noticed is the collaboration is something that, I haven't seen previously in medicine. And I love it.
Last time we talked, you were using the hydroxychloroquine and azithromycin. What are you seeing? What are the results there?
So, it depends. Now, if you ask me, when I look at the patient, if you get hydroxychloroquine or azithromycin or not, I don't know if that's actually the drug that is changing things, right? So it's not like an antibiotic where you come in with an E. coli bacteremia or you come in with an E. coli urinary tract infection, we give you an antibiotic and you get better. I don't know if azithromycin and hydroxychloroquine are actually doing that. If you put me to the test and put me in the corner, I would say it's probably not doing that. I think the patients who are getting better are just getting better. With that being said, I am one that believes that one of our mistakes in the healthcare system, at least in studying things, is timing is of the essence. Timing is important. And so I do think that certain therapies, if instituted timely and at the appropriate time, then they will lead to someone improving. And so I don't know if our studies in regards to timing are helping us with hydroxychloroquine and Plaquenil or any of the other therapies as well. So, I don't want to sit here and say and give no hope, but I will say that I don't know of a situation where I said, oh, I gave him hydroxychloroquine and Plaquenil, and that patient turned around right away.
Yeah. Remdesivir is the other therapy that seems to get a lot of response. I just saw a New England Journal of Medicine article saying they saw a 65% response rate improvement in those patients. Are you using remdesivir, and what's it doing?
Yeah. So remdesivir is a viral RNA polymerase inhibitor. In other words, it doesn't allow the virus to produce the proteins it needs to survive. I think that's the most promising therapy in addition to other therapies, which I'll get into in a moment. But in that trial is being heavily criticized because it didn't have a control arm right now. And it doesn't matter. If there's a therapy that I think works, it's that one. And I think that remdesivir does actually lead to improvement in these patients when given at the appropriate time. And I have seen it work in some patients, and I have seen some patients that don't get the drug that do get worse. Because again, when you're studying these drugs and they are given either for compassionate use or just to given in a trial that a lot of hospitals are a part of, some people randomize and get it, some people randomize and don't get it. And so, yeah, you do see some differences there.
All right, I want you to stay on the line with us here, Jamie. And also, we have in the studio Terry and Caitlin. And we're going to jump out to the phones now and take a couple of calls. Joel, go right ahead. Tell us about what your world is, how you're feeling COVID-19 in your world.
Yeah, hi Lee. Thanks for having me on. One of the things that I'm involved with is a lot of the long-term care centers. I help run a group that actually provides nurse practitioners to do psychiatric and medical care and long-term care. We cover over 100 facilities across Northeast Indiana. One of the things that we're seeing definitely is with isolation and the mental health component of this, the facilities are doing a really good job trying to involve activities. But one of the things we're definitely seeing is the mental health aspect of this. I think somewhat being highlighted a little bit more for our elderly at-risk population. And I think these facilities are doing a really good job trying to involve this. And one of the other things I would encourage families to do is continue to use the virtual health check-ins like FaceTime or some sort of social media to definitely help continue to boost up the spirits in the facilities.
Yeah, I can imagine that's tough when you can't see family members at all for weeks and weeks on end. When you're in that long-term care facility, family is the one thing you look forward to most.
And Joel, we've talked a lot about how not only is it affecting our long-term care facilities, but also people in their homes. We've talked a lot about patients who have histories of addiction and mental health disorders. And isolation can be really tough for these patients, and we know that it can worsen diagnoses like depression and alcoholism. So we worry not only about those older adults in long-term care facilities, but patients who are at home who may be really struggling with isolation as well.
Yeah, luckily I think there's resources out there now with the updated CMS guidelines and some of the new National Institute of Mental Health. There's some 800 resource available that's getting covered for telemedicine, which that's the other part we see is the uptick in telemedicine and kind of the push for telemedicine. I think, earlier you talked about where this is heading and how to revolutionize some of the healthcare components. I think that's one down the road. Hopefully that will be a little bit more robust to improve kind of access to quality and specialist availability to be able to do telehealth.
Joel, we got to move on, but I appreciate your call. Let's jump to Jim. And Jim, what's your question for us or your experience with COVID-19?
When you have patients who have similar age and physical condition, you have such a wide range of symptoms. Some are extremely mild and some are extremely severe. Do we have any idea what reasons there are behind that?
Jamie, that one's for you.
So he said some of the symptoms are really mild and some of the symptoms are extremely severe. So the reason that people have severe symptoms is really because of the body's response to the presence of the virus, which we're finding is the problem, really. What I mean by that is once the virus shows your body that it's arrived, your body then decides, how am I going to respond to this? Am I going to be calm about this response, do what I need to do, and move on? Or am I going to overreact to the presence of the virus? And that's all dependent on genetics, really, and probably the viral load that you're exposed to. And so that's what we're seeing is we can see activation of the immune system, and people have high fevers, people develop some low blood pressure. All of the white blood cells, at least the T cells in your bloodstream, will rush to the lung, and they'll be low in the bloodstream, and that creates what we call this cytokine syndrome, this cytokine storm, and that leads to the severe symptoms. And so some people handle it well, some people don't. And unfortunately, I can't tell you who you are by looking at you in the street. I can only tell you once you're in the hospital and I obtain certain lab values.
So by then, you're chasing a moving target, and you've got to just hope that you're ahead of its momentum, right?
Yeah, you're chasing a moving target. And remember earlier when I had mentioned about timing, this is when immunomodulating type of medicines, meaning medicines that are going to have an effect on your immune response, would probably be beneficial, is really early. Unfortunately, those medicines would probably be beneficial before you get that organ damage. And so physicians are having trouble identifying an objective parameter to use to pull the trigger.
Yeah, I getcha. Hey, stick around there, Jamie and Terry and Caitlin. We're going to take a break, and then we'll be back with more of this edition of the HealthCall Live Radio Hour. And if you work in healthcare, we'd love to hear what your experience has been. Call us at 800-333-1190. We'd love to hear from you here on the HealthCall Live Radio Hour. Hey, thanks for sticking around here. We are back with you on the HealthCall Live Radio Hour, talking this hour about the impact that COVID-19 is having on healthcare workers. And if you are involved in caring for these patients, or just if you've been affected by it as a healthcare worker, phones are open for you at 800-333-1190. Also on the phone with us is Dr. Jamie Rutland, pulmonologist and intensivist in Los Angeles area hospital. He just came off his shift in the ICU. Also here in the studio are Caitlin and Terry. They are involved in nurse education here in our community. Just as we were coming out of the break, Jamie, I asked you a question about the availability of medications that are required for patients who are on ventilators. That's a new shortage that's developing around the country. Can you explain what those meds are for, and then are you facing a shortage?
So whenever you put somebody on a ventilator, you hear a lot of these, a lot of civilians will talk on television and say, oh, my mother or my brother is in a coma. So what we do to keep people comfortable on a mechanical ventilator when you have a tube down your throat is we put you on sedating agents. So these agents include medicines like benzodiazepines, a popular one called propofol, which everybody heard about during the whole Michael Jackson thing. And what they do is they keep you sedated and calm and comfortable and sleepy while you're on the ventilator, so you're not too agitated, because anybody that has anything plastic down their throat all the time is going to be agitated. So those medicines, when you use them on an abundance of people, right? So say your ICU typically holds 20 people, but now you've expanded and it holds 60 people. You start to run out of those medicines, and the pharmaceutical companies cannot keep up with that production. And so you do develop a shortage over time, because a lot of times it's not worth it for pharmaceutical companies to produce certain medicines because it affects their bottom line. And this I just know, as my sister-in-law is an executive at a pharmaceutical company, and we have these discussions. But this is what can happen. And so I haven't experienced it at my centers here, but I think it's because, as we talked about earlier, California shut down the state pretty quickly. And I don't think that we have seen that surge either yet, or that surge isn't coming. So we don't have those drug shortages at my facilities yet.
Well, that's good to hear. What about the long-term impact of being on those meds? If I'm 80 years old and you've got me that heavily knocked out for, how long are these patients on a vent? A week? 10 days?
You're so correct. Again, that's one of my pet peeves is, why do we have this person on the vent? Why are they on so much sedating medicine? We have to get them off of the medicine. And in fact, when you look at the elderly population, there's certain medicines that we do not like to use because it takes them so long to wake up, so to speak, and get them off of that breathing machine. So you're exactly right, but we pay attention to that as physicians as we're rounding.
Wow, yeah. So Once again, the cure is sometimes worse than the disease. Wow. What do you think it's going to take for us to get out of this thing, Jamie? Is it going to be antibody testing, or what's it going to take?
Great question. I think for the country to move forward and open up, so to speak, I do think that the serological antibody tests are of the essence. And the reason why I think that is when you're exposed to a virus, your body will produce certain antibodies pretty quickly called IgM. And then after about 7 to 10 days, it transitions from IgM to antibodies that are called IgG. And when you have these IgG antibodies, basically what they are in your bloodstream is they're a surveillance system, and they'll notice the presence of this virus and neutralize it quicker, right? And then you have these memory B cells and T cells that help these antibodies become manufactured. And if you go out and you test people serologically and you get that IgG, you can actually you can actually know that that person is quote unquote immune from the illness. They've been exposed, they developed antibodies, and now they can go take care of COVID patients and be worried that they may not get the illness, right? And you'll actually know who has had the illness in the country, and it'll tell us how much of what we call a herd immunity we may have. What a herd immunity is if you have 10 people in a group that all live together, and they all were affected by a certain bacteria or by a certain virus, and 9 out of the 10 of these people developed antibodies towards it. That one person that didn't develop antibodies is protected because no one around him is going to contract the illness because they're immune. That's called herd immunity. And so that's how it works. And when you have a serological test that can test to see who is immune to the illness, you can almost predict what type of herd immunity you're going to have.
And I have read that we're going to need upwards of 60% herd immunity to prevent this thing from keep bouncing back, kind of like the flu does now, comes and goes. And so it's going to take us a while to get to that 60%.
It's also really the importance of our vaccination and getting a vaccine out soon, too. That, is how we prevent the flu each year from being as significant and severe as it could be on our population is through vaccination. So I think that's obviously the antibody testing, along with developing a vaccine and getting that manufactured and out quickly to the public, is going to be our key.
Ladies, I'm going to put you on the spot here and ask you just to kind of have a little back and forth with Jamie about some insider baseball stuff. What do you want to know as he's out there on the front lines?
Well, Jamie, this is one thing I think is interesting for me as a primary care provider who takes care of vulnerable patient populations. I worry right now that we've put primary care on a back burner, and I think unfortunately, our healthcare system tends to put primary care on a back burner, which is why we have such significant chronic illness in this country. So I worry that, if we continue to keep primary care services and screenings and things kind of at a halt, that you in the ICU are going to see this in 6 months from now of patients coming in with ulcers from uncontrolled diabetes because it wasn't being managed appropriately. So hopefully our telehealth services are picking up on that a bit, but what are your thoughts on the long-term complications that are going to come from this, not just specifically COVID related, but what we'll see in a year from now because of it?
Yeah, what a great question. I do some primary care in my practice because I do internal medicine, pulmonary, and critical care. And what we've done is we've transitioned from more of an in-person visit to a telehealth visit. And I think what you're going to find over the course of the next 6 to 12 months is that physicians are going to become more efficient at telehealth and being able to manage things sort of from a distance as we recover from the presence of this prevalent virus that we have going on right now.
Yeah, we've seen a lot of our physicians and nurse practitioners moving to telehealth services, for sure.
Yeah, and I just think it's going to create a more efficient primary care provider. As I could say, I've become a little bit more efficient at the telehealth, but I do worry about exactly what you say. There's still common illnesses that happen, and there's still common things that lead to significant complications, and we're probably going to see more of that. And I agree with you. I think that primary cares, we need to have a strategy and a plan to understand who has contracted the illness, who has developed antibodies, so we can get back to our routine of taking care of patients and preventing illness forward.
That's a great place to end it. The clock tells me I have to. Cedric Jamie Rutland is a pulmonologist and intensivist, also a spokesperson for the American Lung Association. He's the founder of West Coast Lung and also the host of YouTube's Medicine Deconstructed. Thank you for joining us, Jamie. Terry and Caitlin, thank you for being here in the studio, and I thank you for listening. We will see you always on the HealthCall Live radio hour every week at 9 o'clock right here on WOWO, 1190 AM, 107.5 FM.